Hi everybody, my name is Schnorr and I'm one of the reproductive endocrinologists here at Coastal Fertility Specialists. We're starting a new segment in our newsletter that we're calling Coastal Quickies. It's an affectionate way just to think about kind of how we can give you kind of quick information that might be relevant to you and your patients. It's a video that you can find with that QR code and using your phone. We've gotten good about that with coronavirus and finding the menus for our favorite restaurants with the QR codes, and we thought this would be a nice easy way to kind of talk over just 3 to 4 minutes about the hottest topics in our field. I'm going to reference a study or two, and in the links below you'll be able to see the actual study that I'm referencing if you want to read it and think about it. Look forward to hearing your thoughts if you have comments about it. What I wanted to talk about today was genetic testing of embryos in an IVF cycle. I'm sure you're all well aware that the majority of eggs ovulated out in nature for women 35 years of age are chromosomally abnormal, and that actually results in an increased risk of aneuploidy of the embryo, lower pregnancy rates, increased miscarriage rates, and increased birth defect rates. There's a couple of studies all over the board, but most of the studies would show probably about 56 to 60% of all ovulated eggs at a woman at 35 years of age are aneuploid. We think sperm, probably 3 to 5% of our sperm is aneuploid. And so the question would become, should we be doing genetic testing in an IVF cycle? When you first think about it, you think, of course, why wouldn't you do genetic testing? And the reason you wouldn't do genetic testing is there can be harm to doing the biopsy of the embryo. Biopsies used to be done on day 3 of embryo growth. That was kind of in the 19 to 2000 range. And then more recently, we've grown the embryos to the blastocyst stage of embryo growth when they have about 150 cells. That's day 5 and day 6 of embryo growth. And the biopsies are now done with a laser through a microscope where we take probably 3 to 5 placental cells, the trophectoderm, out of the embryo, and we can send that for genetic testing. So a variety of different testing techniques. The best ones are called next generation sequencing, which allows us to see with high resolution each of the chromosomes. It's done for aneuploidy, looking for aneuploidy, and we can find segmental defects and other problems. The cost of it, probably about $4,000 would be the financial cost to doing that, but also the cost is probably the biopsy at some level will lower pregnancy rates. And so when we think about it, we think, well, the patients that will probably benefit the most would be the older patients, but in tandem, those are the patients who also have a decreased number of eggs and typically a decreased number of embryos, making, frankly, the cost of the biopsy kind of more significant for them because each embryo is going to be more precious and would have a higher harm if it was actually harmed. Study done in 2019, which I think about a lot, by Santiago Munné, who is a very big kind of geneticist in our field. Studied infertility in Australia, it was published, studied 661 patients who were in an intention to treat analysis. These patients were 25 to 40 years of age, and they simply said, we're going to transfer an embryo random by random, either based upon morphology, which is the size and shape and how they look, or based upon actual genetic testing of the embryo. And when they did that in an intention to treat analysis in all comers coming in, there was no improvement in the live birth rate between transferring the embryo based upon morphology and transferring it based upon genetics. Now again, in that intention to treat in all comers included some younger women, 25 to 35 years of age, and that younger age group probably not going to have as much of a benefit. The second part of it they did a pregnancy rate based upon morphology in the first embryo transferred without an intention to treat. And in that, it showed a 50% chance of pregnancy with genetic testing and a 46% chance of pregnancy based upon morphology alone. Again, that was all comers. Well, what about the patients that probably matter the most? What about older patients? Well, if you looked at the 35 to 40 year of age group patients, and then you looked at the pregnancy rate based upon morphology versus PGT, the genetic testing with the first embryo transferred, the pregnancy rate was better with the first embryo transferred, 50% compared to 31%. So, if you're going to say, patient, no matter what, we're going to transfer over time all of your embryos, the intention to treat analysis will show that the chance of delivering a baby is the same without genetic testing as it is with genetic testing. If you're going to say, what's the pregnancy rate with the first embryo transferred, it does seem that we can select the better embryo with genetic testing in women generally greater than 35 to 37 years of age. I think the summary when I'm sitting with a patient is, if you're greater than 35 years of age, we should have the discussion. If you're greater than 35 years of age with a low number of eggs and embryos, we probably should not do genetic testing because of the harm of the embryos. If you have a large number of embryos because you have good ovarian reserve, but you're older, genetic testing is going to play a role in quicker finding the best embryo, transferring the best embryo, getting you to pregnancy quicker, which will save you money in the long run, lower the miscarriage risk, which has a cost and emotional toll too, and also might help get you to baby number 2 and baby number 3 quicker. So it's a complicated question with a complicated answer. It's not one size fit all, and I think that's really the value they have in the consult. So with that, I look forward to hearing any questions you might have about this and appreciate a couple of minutes with you today. Take care. Bye-bye.